Great. So thank you so much for inviting me. And it's a real privilege to connect with our DGIM partners in health. Today, we're going to talk a little bit about outpatient approach to long COVID. And I hope you'll come away from this lecture with lots of little tricks and tools to ideas on how to work up, manage, and interventions that you can use for people with both long COVID as well as fatigue. First of all, disclosures, I did author the book on long COVID, so some of the slides will have images from the book that I'll be sharing with you. So our learning objectives today is we're going to talk about outpatient approach to long COVID. We're going to talk about 5 key drivers of both long COVID and fatigue symptoms. I'll go over 3 main cellular immunologic pathways to get an understanding of some of the choices that we make for both diet and nutrition. We're going to talk about mitochondrial function and 4 key ingredients and nutrients to optimize it. And little hint, it's not CoQ10. We're going to talk about a laboratory workup for long COVID. We're going to talk about dietary approaches to treating fatigue and long COVID through nutrition. And we're going to list some options to reduce stress physiology. So hopefully you'll have lots of tools after this. Before I get started, I wanted to talk a little bit about the Optimal Clinic. So we are expanding. Lakshmi Santosh, through her leadership and her vision, opened up the first clinic, which is the Optimal ICU clinic, as she started seeing patients who had recovered from long COVID but hadn't recovered. They still had a lot of post-acute sequelae of the virus. And these were patients who were hospitalized or had been in the ICU and had long-term sequelae. Last year in 2023, she and I connected and she invited me to open up a clinic through the Integrative Health Center as she started seeing more and more patients were no longer being hospitalized as there was more herd immunity and more vaccines available. And yet there were more and more people who were developing these weird syndromes of fatigue and brain fog and exercise intolerance. So I opened up the long COVID Integrative Health Optimal Clinic in June of 2023, and we have been serving patients for over a year now. And that clinic has become so popular that it's been quickly overwhelmed by the demand. And so we are delighted that this academic year, our efforts have expanded and Iris Huang has joined the Optimal Clinic team, and she has opened up an internal medicine branch and is ready to accept patients. And that way we can increase our capacity to care for patients. And there is also an option for patients who just want more standard internal medicine approaches. And maybe she can give the talk next year. And then Lakshmi has stepped down and her leadership of the Optimal Clinic to pursue other amazing endeavors. And so we are now looking forward to working under the leadership of Leah Witt, who will be taking over the directorship role. So there's 3 Optimal Clinics now. Leah Witt, she will be accepting referrals for patients who were either hospitalized or who have pulmonary symptoms. And then both I and Iris Huang will be accepting patients who were not hospitalized, don't have pulmonary symptoms, but have other symptoms of long COVID. And like I said, right now, the Integrative Health Clinic has a pretty big backlog. So we're very delighted that Iris Huang will be able to increase our capacity. So when you do put in a referral to Optimal, you will have these 3 options that you can offer patients. So lessons learned from the long COVID series. Long COVID it's amazing to see that it can be addressed with 5 simple interventions in most people. And in the case of Integrative Health, it has been implemented over a series of 3 visits that are spaced out 2 weeks apart. So every 6 weeks, we have a new group medical visit, and each group medical visit serves up to 10 patients. But before I go into the details of what we go over, I wanted to talk a little bit about the parallels between long COVID and HIV Several years back, we were forced to reckon with a pandemic with a new virus that our immune systems were naive to. And it took a while for us to recognize what was causing HIV and to understand its physiology and to come up with remedies to treat HIV. Fortunately, that has taught us so much about the immune system. It really fostered an age and an era of research that has really expanded our knowledge about immunological mechanisms behind chronic viral infections. There are similarities between COVID and HIV. Number one, it's a highly mutable virus. We keep having to deal with new strains several times a year, sometimes rendering vaccines or other medications less effective. So there are some similarities there. Also, long COVID is now starting to spur research into one of medicine's most neglected diseases, which is chronic fatigue syndrome and myalgic encephalitis, which is really just the older cousin of long COVID. A lot of people with CFS-ME oftentimes have a post-infectious sequelae that seems to linger and doesn't resolve. And so I'm very optimistic that I'm hopeful that we will have a lot more knowledge spurred by research and that long COVID has put a spotlight in this somewhat neglected illness. But some of the lessons we've learned from the long COVID GMV series is in a series of just 3 medical visits, we cover in the first visit, diet. And diet is not a one-size-fits-all approach. So I'm going to talk about 3 main diets that I recommend for patients in my group visits. In the first visit, we also order a laboratory workup. And then 2 weeks later, in the third visit, we go over the laboratory results and I implement a supplemental regimen that covers any nutrient deficits and also immune pathways. And then in the last visit, we talk about how to exercise, and the tip is slowly and with pacing and incorporating periods of rest. And we talk a lot about the brain, neuroinflammation, and how to de-stress and optimize vagus. So inflammation is one of the key drivers of long COVID, and I talk about inflammation with a big I. There's a lot of different types of inflammation. Generally in fatigue, there are 4 big buckets that contribute to fatigue symptoms, and inflammation is one of the biggest buckets. Now, when we think of inflammation, we're probably thinking about classical inflammation. When you exercise and you have fatigue and you have joint pain and some muscle aches, a lot of that is stemmed from classical inflammation. And but one really, really big pathway in both chronic fatigue syndrome that is under-recognized and in long COVID is histamine-mediated inflammation. That can cause a lot of fatigue and brain fog. Histamine is a biogenic amine that is bioactive in the brain, and it can cause excessive activation and even neurotoxicity when in high amounts. So this is a really underdiagnosed and underrecognized pathway of inflammation in the body. Autoimmune inflammation, we know that COVID can both exaggerate autoimmunity that is present and cause people to flare who have autoimmunity. We also know that COVID can spur de novo autoimmunity, in other words, create a new autoimmune syndrome due to excessive immune inflammation. Gastrointestinal inflammation is important as it can overlap into systemic inflammation, and neuroinflammation seems to be present in most people with brain fog, migraines after long COVID. So that's big bucket number 1. And then reactive oxidative stress from DAMPs, damage-associated molecular patterns, can happen. And of course, we live in an age where we have increased environmental toxins. And so that is a big burden on our body as well. Nutrient deficits, the laboratory workup is really good at identifying those, and it becomes even more important for mitochondrial health, and we'll talk about the mitochondria in a bit. And then stress physiology is really important as well. Here's another way to look at it. So inflammation, big bucket with a big I, 5 different subtypes, and yet neuroinflammation can feed into stress physiology. And then stress physiology can, of course, loop back and cause systemic inflammation. So now we have this looped, self-reinforcing mechanism that can be very hard to break. So it's important to both address inflammation, but also address stress physiology to try to break that cycle. Another way to look at inflammation and the 5 subtypes is that classical inflammation is mediated by interleukin-6, and it can be indirectly measured by C-reactive protein. Histamine-mediated inflammation is mediated by interleukin-4 and interleukin-13. Interleukin-13 can activate mast cells. Autoimmune inflammation is mediated by interleukin-6 and 17. And then neuroinflammation, there's no great way to measure it. So usually we look at it clinically. CTs, MRIs don't really show the kind of neuroinflammation you see in chronic fatigue syndrome. Gastrointestinal inflammation, a lot of times you can suss that out clinically if patients are having a lot of symptoms of IBS, IBD, or food sensitivities. I know this is a really busy slide, but bear with me. I just want to talk about 3 main pathways, immunologic pathways that are really important for both fatigue and long COVID. So here's interleukin-6. Generally, our body has a certain amount of naive T cells, which can become activated and then can differentiate into different kinds of T cells, depending on the environment that they see. So if an activated T cell sees a lot of interleukin-6, it's going to mature into a Th17 cell, and Th17 cells produce interleukin-17, and that can cause tissue inflammation. If excessive, this can create damage-associated molecular patterns that can promote autoimmunity. And of course, there is a Th2, Th17 coactivation that can happen. And these 2 pathways are really important, very often what I see in chronic fatigue syndrome and in long COVID. If the activated T cell sees a lot of interleukin-4, it's going to maturate into a Th2 cell, and that will produce interleukin-4 and 13, which activates histamine and mast cells, and then interleukin-5, which activates eosinophils. And all of that contributes to allergy, histamine-mediated disorders, and mast cell activation, something that's very common with long COVID and chronic fatigue syndrome. They will cause Th1 cell maturation, and Th1 cells produce interferon gamma, and that's really important for cellular mediated immunity, your ability to fight off viruses, but also tumor surveillance. When you have overexpression of Th2 and Th17 pathways, what happens is this diminishes, and you lose your cellular immunity. And therefore, it's absolutely possible to have an immune system that's chronically inflamed, yet ineffective at fighting viruses. Interleukin-6 is also really important in platelet activation, and that can drive microclotting and endothelial dysfunction, another pathway that's seen in long COVID. Dr. Montoya also studied CFS, and he found that there were cytokine patterns that were very similar in ME and CFS patients, mostly that teaches the immune system is higher. And so it's as if your body is trying so hard to suppress inflammation that it compromises your immune system. So there are definitely immune derangements that happen in CFS. I want to talk briefly about mitochondrial energy. A lot of people talk about CoQ10, but I'm going to jog your memory back to high school biology and remember this citric acid cycle here. So we're going to remind ourselves of this. Generally, our cells derive energy from 3 main energy sources: fats, carbs, and proteins. And fatty acids, allow me to amplify this a little bit. Fatty acids get broken down by beta oxidation, and those enzymes require magnesium and B2, acetyl-CoA, which then gets fed into the citric acid cycle. And then the citric acid cycle, it needs iron, glutathione, more iron, B2, and B3. And then those substrates get fed into the electron transport chain where you make energy. And CoQ10 comes down here at the very end. In addition, there is a back door where fats get fed into the electron transport chain, and that's called the carnitine shuttle. And the carnitine shuttle also requires vitamin B2 to function. So you see that vitamin B2 is really important. Personally, I never checked B2 until I started digging into mitochondria and energy. And half of my patients in the GMV visits have vitamin B2 deficiency. So it's a really, really important vitamin to check. We can check it. It's covered by insurance. Definitely something that can be done from a primary clinic perspective. So you get a sense that magnesium, riboflavin, iron glutathione, or NAC, which is the glutathione precursor, are all really important. And if somebody has riboflavin deficiency, I like to add L-carnitine because I can assume that there's a possible L-carnitine dysfunction, and those patients usually benefit. B1, B3 is also important. So here is another picture of the carnitine shuttle, how it transports fatty acids into the mitochondria, and it does so by a process of oxidative phosphorylation, by producing acetyl-CoA and ketone bodies. So very, very important. So speaking of these nutrients, I want to talk a little bit about iron. I personally was taught not to care about iron deficiency, or even if women were anemic, because they're women. They're supposed to be iron deficient and anemic. And yet I have found this to be really critical and important to address in my fatigue population. In addition to iron deficiency, inflammation causes an upregulation of hepcidin, and that further impairs intestinal absorption of iron from food. So it becomes very difficult for women to be able to improve their iron status. I like to check ferritin instead of iron because, as you saw, iron is an intracellular and not just in heme, but is also needed for mitochondria. And ferritin is a better surrogate of the total iron body stores. Oftentimes, serum iron is normal, but ferritin is very, very low. So it's more sensitive. Now, most people, if you look at the range of iron, it's ridiculous. It's 15 to 350. There's no way that one body is okay with that wide of a range when oxygenation and mitochondrial function depends on iron. So the World Health Organization more recently in 2020 has thought to change the parameters of iron deficiency. And it says here in 1.2, in individuals with infection or inflammation, a ferritin concentration below 70 in adults is used to indicate iron deficiency. And I like to aim for a iron level of, or a ferritin level of 100 nanograms per liter. That avoids too much iron, which can also be problematic. And it seems to be that Goldilocks zone where you're oxygenating well and you're able to have good mitochondrial function. So with all of that preamble, the blood work that I order for my patients with long COVID includes B2. Hopefully you understand now why I order B2, ferritin. I order histamine tryptase to check histamine-mediated inflammation, CRP and ESR to measure classical inflammation, vitamin D, because as vitamin D goes up, I see CRP going down, zinc and copper, because zinc is very important for immune function, but also for dopamine production in the brain. And many people have zinc deficiency, but excessive copper. You want to check both, because what you don't want to do is give zinc, and if the copper is low, make the copper go down further. However, copper deficiency is rare. What I see mostly is copper is 200 and zinc is 50. So copper is 4 times the amount of zinc, and you want them to be about 1 to 1. And then D-dimer fibrinogen and vascular endothelial growth factor are to see if there's endothelial dysfunction and possible microclotting. I do an EBV early antigen and an IgM antibody to see if there's EBV reactivation, which is common in long COVID. And optionally, I do a cytokine 13 assay. This is a miscellaneous send-out test through Arab Labs. All of these are covered by insurance. For Medicare patients, I do have to say vitamin D deficiency to get this covered, but otherwise everything is covered under diagnosis of long COVID or fatigue. I do ask for fasting for these labs because the vitamins I ask patients to hold their multivitamins for a day before, for 24 hours, and to arrive fasting. And for the histamine tryptase, I do ask patients to stop any antihistamines for 7 days. Otherwise, the test will look normal and you won't be able to really assess their histamine pathways. So after that, you do want to address nutrient deficits. So we talked about B2 and the mitochondrial pathways. B2 also is needed for brain and nerve function. It helps to recycle glutathione, and it is a cofactor for a liver enzyme called ALDH that helps to clear histamine from the body. So it's a really important nutrient. Iron, also a cofactor to get rid of histamine in the liver. ALDH uses B2 and iron. And then it optimizes oxygenation status. There is some evidence that people with chronic fatigue syndrome have a preload failure. And guess what? Iron deficiency can contribute to preload failure in the heart. Vitamin D, ideally around 50. It's okay if it's a little bit over. People do not become toxic if their levels are 55. They can become toxic if the levels are 70 or above. So I do like it to be 50 to 55, especially in autoimmune illness, because it is so driven by interleukin 6. And then there is evidence of higher mortality from both COVID and higher degree of long COVID with vitamin D deficiency. Zinc and copper we discussed. We want to check the copper and look for a approximate 1-to-1 ratio. And zinc is really important for immune function. And then if riboflavin is deficient, consider L-carnitine supplementation as well. So with that, I want to share the long COVID supplement protocol that I give my patients. We address 5 targets of support. This is free to download. The NIH article is listed in this slide. And I know this is another busy slide, so bear with me. Here's vitamin D, 5 to 10,000 units, get your levels to 50. Zinc, 30 milligrams twice daily. Vitamin C, it helps to decrease histamine-mediated inflammation in the body. It's also an antioxidant. We use slightly higher doses. In long COVID, we know that insomnia is really big in long COVID, but melatonin also seems to have some neuro anti-inflammatory benefits, and so we use a little bit higher doses. Quercetin is really important because it's an antihistamine and a mast cell stabilizer, so 1,500 milligrams in divided doses. Fish oil for general anti-inflammatory purposes. A high potassium diet because the cell membrane has a sodium-potassium pump, and cells like to clear debris through the potassium pumps. So if you have a high salt diet, but you're not really adding potassium, your cells are not able to clean themselves out as well. And you do want to get rid of cellular debris. NAC is the precursor of glutathione. I don't know if you guys remember in the ER, we used to give that IV to people with liver dysfunction or with Tylenol overdoses. So it is a big liver helper, and it is important to decrease oxidative stress in the body to help fatigue. We use pretty high doses. For NAC, we're using about 3,500 milligrams. For glutathione, we're using about 2 grams in divided doses. Oops, let me go back. And then I use things like turmeric or bromelain. I really like bromelain because of its antihistamine benefits, but it also is an antifibrinolytic. So it does have some proteases that for people who have high D-dimer fibrins, it's nice to be able to improve blood flow. So my targets include correcting iron and D deficiencies, zinc deficiencies, anti-inflammatories, antioxidants, magnesium glycinate at night to help with sleep. Glycinate and threonate are highly bioavailable. They don't cause diarrhea and they become intracellular. So these are 2 good forms, plus an antioxidant. My next target is to address immune pathways. And so quercetin is to address this Th2 pathway, which is very pronounced in chronic fatigue. Oops, sorry about that. And then bromelain also addresses interleukin 4. Correct any vitamin deficiencies. Perilla is a new one. It also lowers interleukin 4, really important for people with a lot of humoral mediated allergic diathesis and fatigue. And we'll talk a little bit about diet, but for people who do have very strong Th2 histaminic pathways, think that those people who have the asthma, the weird rashes, the inexplicable sort of syndromes, I might pair it with a low histamine diet. Dr. Larry Afrin, who's a leading scientist in mast cell activation, does say that mast cell activation is quite common in both chronic fatigue syndrome and in long COVID. COVID is very prolific at activating mast cells and platelets as well. And early on in the pandemic, we were using famotidine in inpatients, and it seemed to have decreased mortality and also decreased ICU admissions. So primary mast cell activation from the virus. For those of you who are not comfortable prescribing botanicals, ketotifen is an H1 blocker, and you can pair that with famotidine, which is an H2 blocker. Here are some potential manifestations of mast cell activation: fatigue, changes in sweats flushing, hyperthermia or hypothermia, dermatographism or rashes, dry eyes, difficulty focusing, tremors, hearing loss or tinnitus or dysosmia, pain or irritation in the throat, angioedema, adenopathy, and sometimes it's waxing and waning. It'll be there one day and it goes away the other day. Airway inflammation like asthma, chronic cough, presyncope, POTS, dyspepsia, GERD, nausea, vomiting, migratory pain, such as cystitis, that is culture negative, migratory bone, joint, muscle pain, headaches, sensory neuropathies, anxiety, depression, insomnia, hyper or hypothyroidism, polycythemia, anemia, and then hypersensitivity reactions. So anytime you have a patient that seems quite mysterious and has these very, very waxing and waning, think histamine. It's a huge, huge pathway. So after I've sussed out the inflammatory pathways with patients, I will usually pair it with the appropriate diet. It's probably safe to say that everybody would benefit from the anti-inflammatory diet. This is the Mediterranean diet. It's a diet that is rich in omegas from fatty fish and plants like walnuts and omega oils, cruciferous vegetables, mushrooms, organic berries, and then avoiding the toxic triad of dairy, sugar, processed foods. Now, there are two modifications of this diet that I give to patients based on their clinical presentation. If patients seem to have a lot of histamine-related issues, or if their labs show elevated histamine or tryptase, I will have them do a low histamine diet. It's very similar to the anti-inflammatory diet with two main differences. Berries are high in histamine, especially strawberries. And then seafood, which is pretty healthy, is pretty high in histamine. So normally I have them adopt a low histamine diet for 3 months, after which they can start reincorporating some of these fermented foods, some seafood, and some berries. This really helps the body to clear some of that histamine-mediated inflammation before you add higher histamine foods. There's a really great handout that I'm sharing with you here. The Swiss working group has the best handout on the low histamine diet. The second modification is if they come in with autoimmunity, if they have MS, rheumatoid arthritis, or if their ESR is like 40 and they have thyroid antibodies, and that involves a gluten-free diet with avoidance of nightshades and legumes and peanuts. Now, probably this is the diet that has the least strong evidence for it. We do have some enticing data that SARS-CoV does cross the human gut and that it creates these distant antigenic immune responses that are related to ulcerative colitis, primary biliary cholangitis, celiac disease, and autoimmune hepatitis. We also know that in models of rheumatoid arthritis, that a gluten-free diet has helped many, and that potatoes have solanine, and that solanine appears to be a glycoalkaloid that creates more gut inflammation. We think that some of the increased autoimmunity is through gut-mediated inflammation, and as everybody knows, our gut has the highest concentration of B cells and autoimmune through the gall to the gut-associated lymphoid tissue. So there's some kind of gut immune connection there, and we think that by decreasing inflammation in the gut, we can calm down the reactivity of B cells and the production of antibodies. This is one of those things where I can just say clinically, I have seen it do wonders, and it could be that sometimes we see things clinically before the evidence shows what we are seeing in clinic several years later. For post-exertional malaise, I like to tell people, don't push past the fatigue, abandon the concept of no pain, no gain. Instead, adopt slow and steady wins the race. And that is a good motto to live by. There's evidence of amyloid tissue infiltration increasing after patients overexert themselves and push themselves into a crash, which means there's actual damage to their muscles. COVID causes loss of muscle, it causes some muscle atrophy, and there is more predominant loss of slow twitch muscle fibers, which are the ones that are strong. So you are working with fast twitch muscle fibers, which are easily fatigable. Oxidative phosphorylation is significantly lower in long COVID patients, and mitochondrial density is reduced after induction of a crash. So you actually lose mitochondria. So therefore, it's really important to have a really, really slow, graded, paced approach to exercise recovery. And I tell patients normally to do prone exercises and build up muscle mass before they do any cardiovascular exercise. Also, for those of your patients who may complain of shortness of breath, but they have a normal chest x-ray, normal PFTs, consider loss of diaphragmatic and chest wall mass. Some patients do say that they have tenderness along the chest wall and a lot of MSK pain, and that they have the subjective shortness of breath, and that can be associated with atrophy of rib cage muscles and intercostal muscles. So here is a picture of healthy muscle tissue with the different kinds of fibers. And here is a picture of a long COVID muscle fiber cross-section. So you see how ratty-tatty it looks and how it's lost some of the architecture, and there's some amyloid deposition. So this is what you're dealing with. Here is OXPHOS capacity. You see that oxidative phosphorylation capacity is decreased when post-exertional malaise has occurred, when they've overexercised. And you see that there's also loss of mitochondrial. This SDH is a measure of mitochondrial density. You see that there's actual loss of mitochondrial density after PEM. So instead of pushing patients to push past the fatigue and do more, I actually tell patients to really, really pace themselves, because it actually sets back their recovery significantly, because now they have to heal from all of that. So for exercise intolerance, I recommend pacing, and that means incorporating 15-20 minutes of recovery time after each exertion. And please note that if they are quite fatigued, that might mean after just cooking a meal or going to the groceries. There are two really great protocols called the CHOP POTS protocol by Dysautonomia International, and also the Utah ADAPT protocol. They have a very, very disciplined, graded, gradual, day by day, week by week, very slow exercise recovery program before you even start walking. I really like to give patients creatine. Creatine helps to build up muscle fiber, and just 2 grams of creatine can make a big difference with post-exertional malaise. And glutamine can be really useful as well. Both of these are used in much higher quantities by bodybuilders. And for shortness of breath, you can refer a patient to cardiopulmonary rehab. You can also just recommend an incentive spirometer so patients can see that they're breathing shallowly and that's why they're short of breath. You can get one of these for $30 on Amazon. You might have some patients who like to be connected and have more biofeedback from their apps. And for those who wear Uro devices and tell you how many hours of REM sleep they had at night, I've had really good reviews from this AeroFit device. It's about $150. And it does give people biofeedback on their volume, and it's almost like having a portable PFT device in your home. So that's quite nice. So the links are below in my slide, and they are free to download. You can share these with patients. Lastly, I want to talk about neuroinflammation and the vagus. I assign breath work to all my patients, and I tell them a little bit about the importance of the vagus nerve. Here's a picture on the left. So the vagus is the longest nerve in the where it is front and center, and where it connects to the larynx, the voice box, your lungs, your heart, diaphragm, liver, spleen, kidneys, pancreas, and digestive health. So it's everywhere. And so people with tachycardia, that could reflect vagal dystonia. It seems to exert anti-inflammatory effects on the body when it is strong. And there is evidence of vagal dysfunction after COVID. It is exquisitely sensitive to the high levels of inflammation that are caused by COVID. So I speak about vagatonia. Fortunately, there are many ways to rehab the vagus because it's sort of everywhere. The outflow branches in the lungs and the diaphragm have stretch receptors. So diaphragmatic breathing techniques are a great way to access the vagus. I teach all of my patients the 4-7-8 breath. Ear acupuncture, there are afferent fibers in the conchae of the ear that you can access with acupuncture, or even just massaging the ear. Meditation, guided imagery, mindfulness are all really great ways to rehab the vagus. And even singing in lower tones like Om, like people do in yoga, they seem to activate the laryngeal afferent fibers of the vagus. For those who are a little bit more technological, transcutaneous vagal nerve stimulation is a type of neuromodulation that is being studied and is very, very successful. Gamma core is one of the devices that has been most studied, but it's quite expensive. Serbomed has also many studies. Neuromodulation for a long time. We have used it traditionally for seizure disorders and intractable migraines, and now there's at least 15 studies on long COVID. It seems to be really well tolerated. I think for me, the limitations are that studies are studying everything between 5 and 50 hertz, and I think we need to know more about like which hertz do you recommend for which kind of patient, and how do you personalize that? So I think the future of TVNS would be by attaching it to some kind of biofeedback device where you can sync it with people's heart rate and find out what frequency is working for them at this time. But needless to say, it's very well tolerated. I do encourage patients to start with just a few minutes a day, like 2 to 5 minutes a day, and increase very gradually, again, pacing. And I do have a lot of patients that just say that their fatigue is melting away. There are two types of devices, ones that attach to the left ear, so they have access to the vagal afferents in the ear, and then gamma core and Truvega, you attach it to the neck where there's some vagal afferents there. Many of you remember we were taught to do carotid massage for tachycardia, and that was so we could stretch out those vagal receptors. I was never able to abort. And then lastly, LDN, this is a microdose of naltrexone. Many of you are familiar with naltrexone because it has the ability to resuscitate people who have a opioid overdose, and it's also used on patients who are on high doses of methadone. This is microdosing. We start with 0.5 milligrams of low dose naltrexone. It does have to be compounded at that low dose. But the benefits of low dose naltrexone is that it seems to have systemic anti-inflammatory benefits. It lowers CRP, but more importantly, it seems to decrease microglial activation. Among the cells that COVID can activate, it can activate microglia, which can cause a lot of neuropathy and neuroinflammation. And activated macrophages are M1 macrophages. LDN seems to shift them into M2 mode. So very good for people who are having weird neuropathies, but also our brain fog. Our brain's a really big collection of neurons. So it can be very helpful for brain fog. It has been first-line therapy in the Stanford Chronic Fatigue Center, so it's beneficial not just for long COVID, but for chronically fatigued patients. And it's very well tolerated. There are some patients who do report a little bit of nausea. Normally that dissipates within 3 days, and that's why we started a very low dose. And then some people report vivid dreams, in which case, instead of giving it at night, we give it earlier during the day. If you're interested, we normally start with 0.5 milligrams and increase by 0.5 every week until after 2 months, they reach a 4.5 milligram dose. The biggest con is that it is compounded, so it is an expense for patients, and some of them may not be able to pay for it. So before I go into neuroinflammation, I just want to show a case of a 32-year-old previously healthy, high-functioning ICU nurse with no significant past medical history, who post-COVID had debilitating neurologic symptoms of ataxia, stuttering, migraines, tremors, short-term memory loss, dysautonomia, fainting, falling, disabling fatigue lasting a year. She had vaccinated and she had been boosted and is now on disability. Because of her anxiety and her weird symptoms, her primary team recommended that she get mental health care, and she feels a bit hopeless. The workup that I did showed that she did have TGLB antibodies. Her ferritin was not optimal, and her high sensitivity CRP was very high. EBV antibodies were normal, ESRs normal, CBC-BMP unrevealing. And then I did a outside lab for brain antibodies, and she had a picture looking like this. Widespread brain antibodies, including amyloid, tubulin antibodies, myelic basic protein antibodies, microglial antibodies showing that there was microglial activation, anti-dopamine antibodies, anti-glutamate antibodies, anti-RAGE peptide. So obviously she doesn't have all of these. She doesn't have MS plus, all of these different autoimmune syndromes. This is a picture consistent with post-viral encephalitis when everything is just active. And so I don't know if any of you have seen this movie or read the book. The book is much better, Brain on Mid. This is a story of a woman who ended up in a psychiatric ward who was a writer after a viral encephalitis. And in her case, she had NMDA antibodies. So I just want you to keep in mind that there's a lot we don't know about long COVID yet, and that there are multiple possible etiologies for the neuroinflammation. You can have EBV reactivation, microglial activation, viral persistence. There are studies showing through the LINK study here at UCSF that up to 10% of patients still have viral protein particles in their body, and their immune system is quite reactive against them. There are people who have super antigenic responses and autoimmune responses to the M spike protein. There's vagal and limbic dysregulation. And then, of course, we know that COVID can directly enter the brain through both the vagus and the olfactory nerves. So there's much that we need to learn. But I want to just emphasize this because when patients report to you strange symptoms, yes, it is important for them to get mental health care, but just keep in mind that there could be a lot of neuroinflammation that we just don't know enough about, and to try to believe their symptoms. I think one of the struggles is oftentimes patients are not being believed that they have a lot of disability that was not present before, especially if the patient never had mental health issues and now they're having a lot of mood disorders. Consider that this may not be a mood disorder, but some post-infectious inflammatory syndrome. So the plan for this lady was a lectin-free diet due to the autoimmune antibodies, all the supplements we discussed, correct her nutrient deficits, and we talked a lot about TVNS, breath work, definitely get mental counseling so she can have support, a lot of pacing, PTOT, creatine to help her with her post-exertional malaise, and low-dose naltrexone for that glial activation. And I also asked her to enroll in clinical trials to try some antivirals in case there was persistence of the virus in her brain. For those of you who like mnemonics, I'm about to wrap up. One way to think about it is we like to take a tiered approach to long COVID. So address toxins with NAC or glutathione, eat organic foods, address and suss out the 5 types of inflammation, and you can get that from the clinical history, and your labs can sometimes help guide you. Eat right for your biotype. So assign either the anti-inflammatory, low histamine, or lectin-free diet after you've been able to suss out patients' inflammatory pathways. Prescribe rest and pacing and vagal exercises, slow graded exercise according to the CHOP-POTS protocol, and then use dietary supplements to address mitochondria, immune pathways, and consider LDN. And it's just amazing to see how even after 6 weeks, the feedback we get, patients start already looking like they have more vitality after they start with the program, even though they've been suffering for 2 to 4 years before that. So there are ways that you can help patients, and I hope this is giving you some ideas on what you can do for your patients moving forward. So these are some of the things that we covered today. And I'm happy to take any questions.